I would like to just very briefly introduce our panelists this afternoon. And so we have Alice Hall, and Alice is the interim president and CEO of HHSC. We have Paula Yoshioka, who is sitting in for Art Ushijima, who is unable to be with us. Alan Weil is going to moderate this group of executives. And Hilton Raethel from HMSA, Janet Liang, CEO of Kaiser Permanente, and Vara, CEO of HPH. So, take it away, Alan.
Okay, good afternoon. It's a great privilege to be able to sit with these leaders in your community. And I'm going to start off with some simple questions, and then we'll get harder as the hour goes on. How's that sound? The theme of the day has been health system transformation. And I think by way of introduction, it would be good to hear a little bit about your own vision for what a transformed Hawaiian healthcare system looks like, and in particular, what you and your institution, organization, system are doing to pursue a transformation goal. And I think since you drew the short straw of the end of the row, I'll go ahead and start with you, Ray.
I told them when we were coming up here, I usually do better when I'm sitting in Paula's chair, but they wouldn't let me switch. Okay, so I get to go first. Frankly, I think that all of us have a shared vision for what we're trying to accomplish. I mean, I think we know and clearly recognize that today's healthcare environment, certainly on a nationwide basis as well as in Hawaii, is growing, and the costs are growing at an unsustainable pace. And so I think right now it represents 17% of the gross domestic product in this country. And on the current trajectory, by 2050, it's going to represent 38% of the gross domestic product. The country will be long bankrupt before then. Now, fortunately, living here in Hawaii, we have we do better than most. We know that our commercial insurance premiums are among I think the third lowest in the country. Our cost per beneficiary service for our Medicare populations are as low as anybody in the country. And so that opportunity gap to truly reduce the cost of health care isn't the same in Hawaii as it is in other places. But we also know there's some fundamental wrongs with the current system, and we truly have to move. And now I'm really speaking for Hawaii Pacific Health, that we have to move from what is a volume-based reimbursement environment to a value-based environment that really focuses on quality first at what I would call the most effective price, not the most efficient, certainly not the lowest price, but where you're going to be able to deliver the highest quality of care that we would want for our own loved ones. And so really every step that we've taken over the course of the last decade or so has been about positioning our organization and equipping our organization to really succeed against the triple aim, right? About changing that patient experience, about being able to manage a broader population of patients, and about being able to do it at the most effective price.
Great. Let's stick with the delivery system. And Alice, I'm going to turn to you to give us an answer to the same kind of question.
Okay. Well, I think Ray stated it very eloquently. We all have the same issues, and we all are aiming for the same thing, which is quality health care. For HHSC, we are all about accessibility. I mean, we are the rural island healthcare providers, and so providing care in all the small communities is really key to us, and we want to continue to be able to do that. In order to transform, what we're doing is we're looking at a lot more partnering. That's the main key for us, is partnering with HPH and Kaiser and HMSA and Queens and all the health plans and UH and all the FQHCs. One example is that in West Hawaii, HMSA is paying for us to have an OB at Hawai'i Health Center, which is an affiliate that we own, a physician's clinic. And that OB then will take the patients that are being treated for prenatal care at the FQHC. And so it's sort of a partnering and a way to give care to someone in the community. So we're looking forward to a whole lot more of public-private partnership opportunities.
And Paula gave us a perspective from Queens.
Sure. You know, what I would say is echoed with what Ray and Alice said, but I think what we're seeing much more in our industry is this consolidation. that we see weaker systems unable to keep up with the changes in healthcare reform. And unfortunately, as we all know with St. Francis West, that was something that occurred for them. They couldn't sustain and be viable. So other systems, and this includes all the systems in Hawaii, have to step up to make sure that we have access to care. And so I think what we're going to see is more consolidation, and we're going to see that with physician practice as well, and we're going to have to be able to come up with strategies in terms of how we integrate all this care across the system, because it's not just really a siloed healthcare market anymore. It's providing for a continuum of care across all services required.
Let's bring in the payer perspective. Hilton, can I get you to give us your sense of what transformation looks like and how you all are moving it along?
Well, there's a lot of different components to transformation, but one of them obviously is payment. Insurance industry, the insurance industry in general, and CMS for many, many years has paid on a fee-for-service basis that's incented volume. And so a significant, if you want to change behavior, you have to change incentives. There are different ways of changing behavior, but if you really want to get some change, if you change incentives and do it in a material way, you can affect change. And so we and many other payers, and CMS is doing this, MedQuest is doing this, are looking at how we deal with providers, how we pay providers, both hospitals and docs, and investing in shifting away from fee-for-service to a value-based model. So the transformation for us is a lot about how we partner with and how we reimburse our provider network.
And Kaiser, you have an integrated view on these issues, so you're probably not transitioning from one payment method to another. What are you doing to support transformation?
First, while my colleagues were talking, I couldn't help but be in awe of the number of you that have chosen to stay until 5:15 to hear us talk. So I want to thank you for engaging in a fabulous agenda around learning about healthcare issues here in Hawaii. And I think you being here at this conference is a good example of how Kaiser views transformation, which is it extends beyond the healthcare system. That in order to really affect change in people's lives, if you think about it, maybe 10% of your life will be spent in a doctor's office if you have an illness. But the truth is you spend a lot more time with your kids at school and in your place at work. And we are now extending our reach beyond the walls of the medical office to engage employers and to engage schools, to begin the conversation of prevention screening, the effects of obesity, diet in exacerbating the onset of chronic disease, and also trying to embrace different types of community institutions. So we've helped to launch the Public Health Institute here in Hawaii, a partnership with the Department of Health as an example to help extend that conversation through a public health agenda. So there's lots of things we're doing. And I think we have a little bit of the luxury to be able to do that because of our structure, as you called out. Some of the issues around incentive payments and moving from acute care to value-based care and focusing on prevention is part of our DNA. So it allows us to take the next evolution and really transforming communities.
Janet, you introduced a subject that I want to take a little bit further. Much of the discussion over the course of the day, and a key element of the triple aim is population health. And as you alluded to, that's not just medical care. So I'd like to ask some of the others of you to talk a little bit about not just sort of at the high level, we all understand that there are social determinants, we need to engage people, but at a practical level, how are you participating in your communities? What are you asking of patients? What input are you seeking at the community level to build a system that will improve population health outcomes and not just improve the organization of the healthcare delivery system? Alice, with a rural perspective, that seemed, and you mentioned partnering and the like, so can you tease out the community engagement and population engagement side of this?
Well, a major issue for us, of course, is the lack of primary care physicians and other physicians in our rural communities. So without having the physicians, you can't have preventative care or any other kind of care. And so a major initiative for us is to help expand physicians, and we've done that in a number of ways. For one thing, we hire a lot of doctors, and we never used to. Another thing is we've created 501c3s that have doctors' offices. But another thing we're doing is the Hawaii Primary Care Training Program. And that is, again, a partnership where HMSA has helped with that, and the federal government and the state government. And we're actually bringing in residents, as well as setting up training systems for a whole team of types of caregivers, so that, which would include psychologists, dentists, advanced practice nurses, and that sort of thing. And the key is that if you don't have the practitioners, then you can't help the patients to become involved and have prevention. So that's the main thing that we're doing, is to try to expand our providers.
And Paula, you talked about the continuum of care, but I want to try to reach again a little bit out of the clinical medical world and find out what you all are thinking about
Sure.
engaging the community.
All of the hospitals had to participate in a community health needs assessment. And so, that was spearheaded by the Hawaii Association for Hospitals, as well as Department of Health, and that was a partnership. And out of that, all the hospitals came up with areas that they felt they could help the community with. Queens decided on diabetes because, as we know, diabetes is a huge issue for our community. At Queens, we're really focused on the Native Hawaiian population. So what we tried to do, or what we're going to do with that, is we're taking diabetes in terms of the programs we're already providing and leveraging those out to the community. We're doing other work in neuro for stroke for the Native Hawaiian population. Comprehensive weight management is another area that we are moving towards education and with our patients. Cardiac care is another morbidity that much of our Native Hawaiian populations faces. And so this is really education that we're trying to get to the community so that people can take better care of themselves. And so as a hospital system, we already are doing much of that, but we wanted to make it and expand that education out further.
Ray, you kicked us off talking about finance, which is appropriate given what it takes to move the system, but now bring in this other side of the population health.
Yeah, that's really the third leg of the stool that I think doesn't get talked enough about in the public forum. I have every reason to believe that our payers will reform and move along with the reform effort. I have every reason to believe the providers will make the necessary adjustments to do what needs to be done. But I don't think we talk enough about the patient and the community role. And not only how do I frankly think we're narrowing it even when we talk about patient behaviors. It's really societal behaviors. And so, much like Paula described, we certainly participated in a statewide community health needs assessment. We've identified certain populations within Hawaii Pacific Health, like our pediatric population, or even our population on Kauai, which certainly there's applicable pieces to the statewide effort, but there's some unique things about Kauai. And frankly, on Kauai, we see some of our greatest opportunities where we can help be part of the leadership infrastructure that shapes a healthy community. Working with the developers over there to make sure that we have the readily accessible walking paths, working with restaurateurs over there to make sure that they have healthy options within the diets, working with the administration over there to enable those types of positive behaviors and remove any regulatory barriers to allowing that to happen. We've worked with the banking industry, who have an obligation through the Reinvestment Act to partner with organizations like Hawaii Pacific Health or other healthcare organizations to truly reinvest in those societal changes that will bring community benefit.
Great. Hilton, there was reference to the payers supporting these efforts. Do you have your own contribution as a payer to these kinds of efforts, or is it primarily supporting and participating in those of those who are actually out there directly delivering care?
Well, we do. There is a limited role that we do pay. I mean, in terms of where we get our funds from, we get funds from federal government, state government. We get funds from employers and individuals who are looking to us as an insurance company to make sure that their healthcare needs are taken care of. But having said that, as we talked about earlier, we're talking about working with much closer partnerships in terms of transformation, but we're also very interested, obviously, in the overall health and well-being of our community and partnering with community organizations, working with individuals, working with employer groups. So it's really fascinating listening to the conversations that are going on here and seeing how closely all our goals and our initiatives are correlated. So that's, to me, that's very, very impressive that we're all talking about improving the health and well-being of the community, and we all have a different role to do that, different roles in doing that. So it's actually an exciting time to be in healthcare. It's an exciting time. I mean, we have significant issues. While we've got, as Ray said, in many ways, the state is doing very well, but there are still significant opportunities. There are still significant challenges that we face, whether it's behavioral health, whether it's obesity, whether it's diabetes. We do have challenges to face, but it looks like we're all working together to face those. So that's impressive.
It is impressive. As a moderator, it's also a little scary. I'm trying to figure out what you disagree on. It seems like you'll figure this out. I can just leave and, I'll come back in a couple of years.
Well, you should have just asked us that. We would have told you that.
Right. You would have told me to leave. That's all.
No, not to leave. Well, if we don't like the question, we may still do that.
That's right. That's right. So just to reassure me that change is actually hard, let's talk a little bit about the challenges you're confronting. And I guess I heard, Hilton, at the end of yours, some of the health challenges of the state, and I think people would agree on many of those. I'd like to know what the challenges are in what you do. What's the biggest barrier you have to overcome to prepare for your role in the healthcare system, as there seems to be a lot of agreement that it should look in a few years? And Janet, I think since I didn't give you a second question because you were my transition, I'll start with you.
I think the hardest thing is going to sound really odd, but the hardest thing right now is some of the new insurance products that we're selling as part of ACA have a deductible feature. All right, so if you heard about them earlier, and higher co-insurance, what you're beginning to see, in order for employers to have a lower premium, they're offsetting by cost shifting to employees. And that has been going on in the mainland for some time, but we're beginning to see that more here in Hawaii. And the challenge for us is that we as primarily caregivers find it difficult when there are financial barriers for our patients to get care. So back in the good old days, as our model was, you paid a $10 copay for what you needed to get. And now when you come in the doctor's office or you go to the hospital and you've got to pay 30% or 20% of a $10,000 bill, or worse, if you've got to pay a $5,000 deductible, and we really needed you to come in for your diabetic foot check, and you can't afford to, that is a barrier to care. And that is something that we don't want to have to sell. We never wanted to do it, and yet the times have changed such that it's what our customers want, and we need to be responsive. So it's an interesting dilemma that we're in.
That's a fascinating answer, and I will say, as someone who travels around the states, not one that I hear anywhere else, because as you note, this is a trend or a shift that occurred in the mainland a long time ago. And so it's interesting to see you face that. I suppose the good news is
it's new for Hawaii.
It's new for Hawaii.
It's going to be new for Hawaii.
Very interesting. Paula, what are you confronting? What's the biggest challenge in this transformation?
Sure. I think everybody knows it's not a surprise. Reimbursements are tough for everybody. And because of that, everybody has to cut back. I mean, that's sort of the natural thing. If you're not able to get reimbursements and revenues, you're going to have to cut the expense side. In the hospital industry, there are benchmarks nationally that indicate that hospitals have to reduce their overall cost by 20%. That's a very tough thing to do when you're looking at how does this impact patient care. What are the things that we have to do away? What are the things we have to do without? In order to make sure that and still provide quality care. So I think that's going to be an ongoing dilemma for all health systems, is how do you sustain yourself over time, just given the environment.
And are there aspects of the transformation, you mentioned consolidation, the continuum and outreach, maybe tackling diabetes, do you see those as a path forward, or is it really just those are two separate agendas? We've got to do cost cutting and we've got to do transformation.
No, because really, if you look at ACA, it's about reducing the cost of health care. And the basic way to do that is make sure people stay healthy. And that's really our charge here, is to do what we can to make sure folks are exercising preventive care. And as health systems, it's our responsibility to assist everybody to do that. And in turn, if you keep people healthy, you keep them out of hospitals. So it's a very linear kind of equation, if you will, but it's not an easy one.
Hilton, what's your biggest challenge?
Well, there's lots of challenges, but one of the biggest ones we have is actually getting the member engaged. As we go out there and we talk to doctors, and we're putting incentives out there for them to work with their staff in a team-based care, patient-centered medical home. We're incenting them to get their patients in who have diabetes or hypertension or asthma, for the kids to come in for their immunizations, for the seniors to come in for their flu shots, which are all good things. And the staff are there in the doctor's office, and they're calling up the members, and it's hard to get, on many occasions, to get the members in. And what we hear from many doctors is that they care more about their patients' health than what their own patients do. And that's a really sad commentary, and part of that, and Janet was just talking about, the dollars and how the dollars are shifting, but, it's one of the reasons why patients have not been engaged in the healthcare is that they've been so divorced from the true cost of healthcare. They don't understand the consequence. I mean, if they go in and they have, $10,000, they go into a hospital and they have $10,000 worth of care given, and then they get upset if they have to pay $200 for a copay. So it's, getting members involved, getting them to understand that they are a part of the system, that there's things that they can do, that they have a responsibility. They need to work with their primary care provider. They need to identify a primary care provider if they don't have one. They need to stay healthy. They need to eat well. They need to exercise. A lot of people are very passive, and so getting people involved, our members, patients involved in their healthcare, is a real challenge.
Alice, biggest challenge?
Well, HHSC is a state agency, and we do have a few unique challenges. We also have the benefit of the legislature, but we also have the challenge of being a political animal. And we don't have the flexibility to make the changes in a timely manner the way that we would like to. We still have to follow a lot of the same laws that the other state agencies follow. Our labor costs are over 70% of our operation expenses, which is way, way above, the national average. And so when we start talking about cutting expenses, it's very difficult to do. And the services that we provide are primarily safety net services, and they're never going to be very cost effective. However, it's difficult for us to justify, our existence sometimes because of the loss of money. And without having capital and without having cash on hand, it's really hard to weather some of these changes. Right now, we're converting from a fee-for-service type system into this pay-for-performance system. And so we're sort of on this shaky bridge where we're all headed in that direction. And in the meantime, we're still really on the fee-for-service. So we're trying to increase our census, but yet really what we should be working on is how do we reduce length of stay and reduce the number of people in the hospitals. And since we are mainly a hospital system, we do look primarily at hospital service lines rather than some of the other service lines. So it is a big challenge for us. We have to change our thinking to being more of a continuum of care, and our services have to continue to grow to include more outreach, home health, hospice, other kinds of services, that more prevention, so that we are spending a lot more of our time in that way, and then converting our revenue model more to a pay-for-performance model.
Depending on the audience questions, I'm definitely going to want to return to that theme, but Ray, you get the last shot at the biggest challenges you face.
We got it all figured out.
Okay. Well, then I'll take some questions.
I'll talk to
from
these
the
guys
audience.
later and we'll help them along.
Overconfidence would be your biggest problem?
It would be humility. Yeah. Frankly, I think Alice hit it. I mean, from a fee-for-service environment to a value-based system, the Grand Canyon lays in between. And the question is how, I don't know that we got a shaky bridge. It's sort of that leap of faith from, the Raiders of the Lost Ark, where you sort of got to take the step before you figure out if the bridge is going to appear or not. And frankly, for those of us who are in a non-integrated system like Kaiser, we've had to virtually create that. Unfortunately, I think within Hawaii Pacific Health, we've developed that kind of relationship with HMSA and our agreement that starts in January 2014. But the Grand Canyon still exists. And the bridge isn't as fortified in terms of the right path and what the pace in which you move across that are. It's not as clear as any of us would like it to be. And for any organization like ours that doesn't own the health plan and be able to move the money around to do the kinds of things like a fully integrated system can do, I think that's going to be our reality for the next several years.
So Hilton, what is HMSA's role? You've got these folks out here saying we share the vision, but there's a bridge, a chasm, a leap, something. How do you help them navigate? Because if they're not there, you don't have a product on the other side of that bridge.
So we recognize the transition. We recognize this is difficult for hospitals in particular. We understand that they have an infrastructure, but at the same time, we're fully committed to the transformation. We're fully committed to value. We're fully committed to outcomes. And so it's a matter of investing in hospitals taking responsibility for a community, for taking responsibility across a continuum of care, and putting the incentives and making sure that there are dollars out there so that as they reduce readmissions, as they reduce complications, as they work on the health of a population, and as the census goes down, that they're being rewarded for that there's an alternative revenue stream that's flowing into the system. So that's what we're working toward. Is it easy? No. Are we going to have to fine-tune this model as we go along? Yes. But is it the right thing to do? Absolutely.
So Janet, other than sort of chuckling at the ill fate of your colleagues here,
No, I'm not chuckling. I'm not chuckling. It is.
how do
it's
you
hard
react to
work.
this, and
Yeah.
what advice can you offer, and yet what challenges still confront you, even though you don't face this financial integration?
So I would say it's not easy just because we're Kaiser. So I'm sure some of you are happy to hear that. It's not easy. And I was just going to take a moment to just agree that in Hawaii we are very collaborative and that we have really good healthcare institutions. We are very fortunate that on an island in the middle of the Pacific Ocean that we have such fantastic healthcare across all of our organizations. We have 4 Leapfrog A hospitals, and there are some cities that don't have that, much larger cities. So the good news is great care is being provided every day, and what we're trying to do is change health status in population and community, right? And therefore reduce cost, right? So what I would say is that financial is big part of the formula, but the second piece is probably it's around the medical practice itself and thinking about evidence-based medicine, right? It's going to be evidence-based medicine. There is care that's provided even in our fine community that is unnecessary and in fact causes harm. And if you're inside the industry, you know what I'm talking about. If you're not, you don't want to know about it, right? You really don't want to know about it. And there's a lot of great, I was going to say the American Internal Medicine Association put together in 2012. It's called the Choose Wisely campaign. 12 professional associations, pediatric, rheumatology, radiology, physicians across the country got together with like physicians and said, come on, you guys, we know what the dirty secret is in our industry, and each of us should come up with the 5 things we should really pause and talk to our patients about before we do, right? And those lists of 5 things per professional society is not well adopted by the physician community in many circles because it translates to less revenue. So that is something that in this community we could promote more heavily. Evidence-based medicine is something that we do practice at Kaiser, and it's easy to adopt, and you don't have to do what Kaiser does. You can take this information that's public knowledge, supported by the medical professionals across the country about the things that we probably should think twice about doing. And yes, it'll affect revenue. However, it's going to be better care. So that's, I think, something that we could do. That's the next step beyond payment reform. And in addition to paying for the right things, you don't pay for the wrong things. Right? And that's a trend that we saw on the mainland quite some time ago. Value-based purchasing is, and CMS, actually the feds are doing this now, is they're not paying for mistakes anymore. You know, if you are a healthcare institution and you make an error that should not have happened, we're not going to pay you for it. And that's scary for a market to hear, but quite honestly, employers probably haven't gotten activist enough in this community if you really wanted to partner with insurers to make change. So those are some things I would say. My industry colleagues may shoot me for saying it, but it is true. If you really want to affect some rapid change, you'd light a fire with some of those conversations.
I'm going to ask one last question from me before I turn to these. Hilton, you mentioned hospitals taking responsibility. Of course, we have hospital systems represented here. I'm interested in if any of you want to comment on the appropriateness, the necessity of it being the hospital as the anchor for responsibility. Obviously, they have great resources, great assets. They're anchors in their communities. They're also where a lot of the money is, which is both a plus, because if we're trying to save some money, we need to get that 20% out. But they're also institutions that are usually not the most nimble. There's a lot of capital and a lot of history and often a lot of pride that makes it hard to shift direction. So I'm interested in anyone who wants to talk about the role of the hospital as the source or the force of change, please.
Yeah,
Right.
you know, I don't know that I would go as far to say that we're the anchor. I would say that it absolutely has to be a partnership across the continuum, of which I believe the hospital has to be a part of. And frankly, if we're really going to change the bankrupting cost trend that is looming in this country, most of those costs are going to come out of the revenue base of the hospital. So to not have the hospital as a key organizing force as part of that partnership is probably not well thought out, because frankly, I'm very well aware of, you know, we're a large organization. The far majority of our revenue comes from our hospital-based services, and we also know that the far majority of the savings and the reductions in the future cost of healthcare are going to come out of our hospital-based infrastructure.
Any other takers? I don't mean to belabor it, but.
You know, I was going to say every one of us is going to need a hospital in our lifetime. So hospitals are very critical to the healthcare system. So, and I was going to just mention that here in Hawaii, we're actually very cost effective. We have some of the lowest costs in the United States for the care that we provide. And our employers have some of the lowest premiums. Actually, we're the 49th state in the United States when you say high premium to low premium of where we rank on what employers pay. The challenge for us is that our federal reimbursement, which is 30% for Kaiser, probably 60%, 70% for a hospital, is one of the lowest in the nation. And so when we talk about federal dollars, we think about roads and bridges and military, we need better federal funding on healthcare. You know, we really are, and that lower reimbursement causes us to cost shift to employers and other sources, right, or the state coffers, and or really puts a squeeze on the healthcare systems here in Hawaii. We are very, very efficient, and that reimbursement from the federal government, even think of someone in Hawaii, if one of our seniors in Hawaii had a heart attack here and needed surgery and got care, we would be paid 30% less for caring for that person if they were on vacation and in Vegas and got paid and went to a hospital there. The hospital in Vegas would get paid more money to take care of that member or that person than a hospital here in Hawaii.
So I have to challenge you a little bit
Yes.
here. You are a low-cost state, and so your Medicare Advantage payment rates are low because they're pegged to
And fee-for-service.
population cost. But fee-for-service rates are set on a national scale with various adjustments. They can't possibly be 30% lower.
The Medicare Advantage is 30%.
Right.
The fee-for-service is lower.
It is
It is
lower.
lower. I don't know the
Yeah,
percentage.
it can't be that much lower.
I don't
No,
think
it
it's
is.
30%, but it's
I just want to
18,
differentiate
15%,
between
yeah.
a
But you know we're
a
100%,
capitated
right.
payment, which in Medicare is set on the basis of the average cost per Medicare beneficiary. So if you have low utilization relative to the rest of the country, your Medicare Advantage capitation rates are going to be low. But fee-for-service rates, payment rates for an individual hospitalization for someone in fee-for-service Medicare are set on the basis of a fee schedule. That
We're
has
high
some.
majority. We're like more than 50% Medicare Advantage in Hawaii.
Okay,
So just be aware
right,
of
so
that.
it's just
We're
it's
a very
just
high Medicare
got
Advantage
it.
state.
Yeah, but it's not a single statewide fee schedule
Yes,
even to
it's
that end.
worse than the Big Island.
There's a fee
Yes.
schedule that, as I like to say, is based on people ask, is it political or is it formula-based? And I said it's based on a political formula.
That's true. Yes.
I won't argue with that.
But I think Janet's point is valid. I mean, we've got a little bit of schizophrenia here in Hawaii because the reality of it is we know there's opportunities to save cost. We know that our emergency room utilization is off the charts high in the state of Hawaii. We know there's pockets like that where there's opportunities to provide better, safer care, eliminate waste, and reduce the cost associated with that. That being said, I still am not convinced that the system as a whole has enough, if the pot is big enough to support the medical needs in Hawaii.
Yes.
Well, so let's take that as a point of departure for another question that comes from the audience. So you all talked about collaboration, and that's great. One of the tools being used for hospitals taking responsibility and for payment around value instead of volume is accountable care organizations, which have some attributes. Partly they may have to be selective on who's included in the ACO, so that's sort of by definition not very collaborative. But they also may require consolidation, which some may prefer and some may be not so happy about, because consolidation, usually there's a bigger and a smaller partner, and the consolidatee may not think it's entirely voluntary. So let's talk about the hard choices that you and the healthcare sector has to make as you move to this alternative revenue base around models like accountable care. How does the collaborative nature of the state fit with a sort of somewhat quasi-competitive structure implicit in accountable care organizations? I know one of you is just going to jump up, be so eager to. Let's see if, Hilton, you want to take that one on? Well, maybe you're the wrong one to ask because you're the payer. So let's let someone on the getting paid side give us a little.
Paula should answer
Who
that
am
question.
Who am I looking at? Who wants to talk about? Okay. Shall I just change the question? Or
Well, why don't we
No, I think-
rephrase it a bit?
You're allowed to
Rephrase
reframe the
it.
question. I'm just, I reframed the one on this card, so you can reframe what I said.
Well, I think we do have a very collaborative nature among providers in the state of Hawaii. But I also think that even within that group, we all know that some organizations are better positioned today and further evolved in the reform effort and have taken different steps or been positioned better to be more successful in the future. There is going to be further consolidation within the state of Hawaii over the coming years. And you're right, there's always we call them mergers, but there's always an acquiring entity and there's always the tensions that come with that. But again, it's about the greater good. It's about how do we go about as a group of providers who are all committed to the same thing, trying to put the mission first and beyond the territorialism. And the question is, do we do that in a way that is respectful of the individual cultures of the different entities and the different provider groups? But I think we're just burying our head in the sand if we don't recognize that there's going to be further consolidation even within the industry here in Hawaii.
Right. I mean, you talk about the ACO models going forward. And I know that HPH and Shirley Queens developing those models of care. How do we integrate physicians into that care through these models? At Queens, we have this thing, love the acronyms at Queens. And this one is, are you ready for this? QCIPN. Let's have a contest. Yeah, QCPIN. It's the Queens Clinical Integrated Physician Network. And basically what that means is how do we work with physicians in a very collaborative way so that we can provide better care, provide better assistance to our PCPs as they deliver primary care. It's a very collaborative model. And so I was a little thrown by the quasi Joe Fighter thing, but definitely I think, I agree wholeheartedly with Ray. This is a time when systems have to collaborate, and things like, or organizations like the ACO is going to do nothing but help and further that cause.
So someone asked, what should a private practice physician do to get ready? And you have a very high share of those in Hawaii relative to the rest of the country. Is it collaboration? Is it joining a system? What are the options available? What advice do you give them other than get ready?
Electronic medical record.
Okay.
They need to have an electronic medical record to start.
And how do they capitalize? How do they get the sufficient capital to do that, both the record and all the training? And
Well, I think that there are programs that help the physicians with that, as well as if they did become in some sort of arrangement with a health system, then they would help them with that. So that would be another way to do it. But having the health record is something that we're working on at HHSC. We're putting electronic health record across our system right now, in addition to getting ready for ICD-10. So yes, we are very busy. But for the physicians, I think that that's one of the things that they can do just to get ready, to be more integrated with the other continuum of care.
I like the question because I think one of the things that physicians can do is think about what it is that systems of care can help them with. So as we looked at the governor's transformation, hi Beth, and Beth is here in red, acknowledge Beth and her work, but clearly what that work did was allow us to think about how is it we're going to integrate primary care, and what is it that the primary care physician needs in order to succeed. And a concrete example of that might be a primary care physician might see someone who may have a mental illness, and the primary care physician may not be trained to really understand how to screen that person. How then can a system help that primary care physician to identify that illness early on and get the right kind of treatment and setting for that particular patient? So it's really a collaboration. Sorry, that was my pen. Thank you.
And presumably that kind of transformation is something both of you would find supportive of your goals for the state.
Yeah, if I can just comment on the models of care, and we recognize very clearly the value of hospitals, and most of us, as has been said, do need hospitals, but we're actually agnostic when it comes to the models that we're dealing with. So we actually work with physician hospital organizations, we work with physician organizations, we work with IPAs. So we believe that there is, again, we are agnostic, we're willing to work with all these different models of care, but we also believe, though, that the day of the solo practitioner just doing things on their own, that's a dying art. Healthcare is so much more complex. You're talking about electronic medical records, you're talking about ICD-10, you're talking about the Affordable Care Act. It's a much more challenging world than what it was 20 years ago. And so we believe that at least if physicians don't have to be employed, and I don't think that Ray would necessarily want to employ all their physicians. I know that Queens doesn't, for example. So is there opportunities for collaboration? Yes, between hospitals and physicians, but are there also opportunities for physicians just to come together, to form a group, to work together as a group, then collaborate with hospitals? Other opportunities to do that? Absolutely. But for individual, as Ray was saying, for individual hospitals to do it on their own is incredibly challenging. For individual physicians to do it on their own, whether they're primary care or specialty care. And we don't believe actually that they should be operating in those silos. We believe that whether they're primary care docs, they should be collaborating with specialists. Specialists should be collaborating with primary care docs. They both should be coordinating with hospitals. So should there be systems of care? Absolutely, there should be systems of care. And that's one of the challenges that we face in Hawaii, because up until recently, 65 to 70% of the docs in Hawaii were in solo or small group practice. We believe that model is going to evolve over the next few years.
Janet, Kaiser is certainly not agnostic as to this.
Yeah.
So.
Well, I don't think people understand that within Kaiser, our medical groups are separate professional medical groups and self-governed with their own physician boards, right? So they have autonomy to practice. And what I was going to say was, beyond administrative issues, really we're at the cusp. We talk about this, the cusp of the golden age of medicine. The science has become advanced through computing technology, biologics, pharmacology, genetics, predictive medicine. We have computer programs that will calculate your mortality, will tell you how long you're going to live. And I think that, so what I want to say is that, and actually patients weren't ready to have that conversation. So science is ahead of what people have capacity for in terms of their conversation. We had patients crying, and we said, okay, we can't do that when they come in for our injured knee anymore. So, what I would say is that it's just a human being can't keep up with it anymore. You go to medical school, you get into your practice, and it's not possible for you to provide the best and latest technology and information to your patients if you're practicing in a kitchen practice. You just can't anymore. The science is growing too fast, right? So the best doctors are teaming up together to take advantage of the knowledge and what they can do and change their practice. And at Kaiser, I think the trend in what we see in our ability to hire demonstrates, I think, the interest in doctors wanting to and understanding that. So, we will have here in Hawaii, if we have a primary care doctor opening, on average there's 10 applicants. So we don't feel the shortage in terms of when we want to recruit. We had an opening for a neurosurgeon, which is difficult to recruit nationally, 35 applicants. There's an attractiveness to practicing in a supportive model, because we're talking about physician integration, but we've got clinical pharmacists who are helping the physicians, clinical nurses, social workers, physical therapists, all working together, and you name it. There's probably a dozen other clinical professions that are part of the team with the physician to take care of a single patient. So doctors are very attracted to that. They don't have to do everything themselves anymore, nor are they good at everything, quite honestly. That's the other thing that we've learned too. So I would say that hard dying art is and probably not the best medicine to be a kitchen practitioner anymore.
I'm going to close with a question that I think maybe ties together the day and was one of the ones I received on the card. It's a state-level gathering. The state government is very involved in the transformation agenda. What's the one thing that you want to say to this room that the state, as the state, could do to support the transformation agenda that you're trying to achieve in your organization? And I'm just going to come down the line, Alice. It may be a little unfair because you're a state or organization, and there may be things you want that you aren't allowed to say publicly, but by the time we get to the end of the line, people have forgotten anything embarrassing you said. So give us your wish list. And there can't be a dollar sign before it. That's the only other.
Oh, bummer.
Sorry.
Wow.
You all.
Wait a minute.
I just took away your talking points. So.
That's really a difficult question for me without getting into just specific things for HHSC. I think that I have to say that I think that the state is being very supportive and is doing a lot for healthcare. I mean, this organization that, today, the Department of Health, through the great leadership of Director Fuddy, the way that they've supported various organizations in the legislature with funding, I really am a little bit stumped. So I think I'll pass to my colleague at the left and let her come up with what more the state could do to help.
Okay.
I think the state can take a very active role in the federal front. I mean, we've had lots of discussions today about the woes that we have with reimbursement. I mean, everybody is very attuned to all of the audits that are taking place. to fund healthcare transformation. A lot of it is really to sacrificing patient care and the ability for clinicians to make decisions because you're so financially penalized. I think the state can really step up and work more closely with the federal government to see if we can get some changes in the current healthcare transformation rules because they're tough. And they are taking a toll on the way we can provide good care for our patients.
Well, I'd like to commend the state for what they're doing with Beth Giesting and her office and Andrew, and I mean, the work they've done today to organize this is truly commendable. I know it's taken a huge amount of work, a huge amount of planning, but getting people together, bringing people to the table, and providing a forum for the various players to talk, exchange ideas, devise standards, for example, about what we're going to work on in different areas. All of those types of things are very, very helpful. Do they have a role at the federal level? Yeah, I mean, I absolutely believe that there's a role. We've talked about the reimbursement issue. I really believe there's an opportunity there to make sure that Hawaii is getting the appropriate funding that it does deserve. So I think there's an opportunity there as well.
Agree with all my colleagues, and I would add that the ACA interpretations rollout will continue to be bumpy. And I think it's going to take us, different departments in the state, working together in a different way to resolve issues quickly and to continue to partner with folks in the private sector to set law and regs so that we can continue to provide the kind of care that we do here today. It's just going to stay rocky for a while.
First, I would, we would want to point out and make sure everyone knows, look, healthcare is one of the reasons we're lucky we live in Hawaii. It's a bright spot in this state, and I'm not sure that as a state we necessarily take the time to recognize and certainly not celebrate that. I mean, we have a lot of really amazing things going on for the people of Hawaii through the healthcare that they're provided. I would also say, as we go down this reform continuum and we hear all the chatter going on a national level, we have to recognize, and I know folks don't like to hear Hawaii's different, but there's not a one-size-fits-all. We are different. We've had the Prepaid Healthcare Act. We have different pockets of opportunity, and whatever we do to move down that continuum, it needs to be with deliberate intent, with laser focus in the areas where we have opportunity, because all we're going to do is disrupt the ecosystem of what we got going well if we don't do it with that level of discipline. I guess the last piece is to recognize, first of all, I believe that Hawaii, we live in a fragile economy. We hold on to a few key elements that really, that our future viability is based on. And I think one of the things that often doesn't get talked about is the economic impact of healthcare. The latest data I saw, and please don't quote me on this, but if you look at from a statewide GDP, you've got the government, you've got defense, you've got at 7% of the GDP is tourism, and last I saw was health services was also at 7%. And I don't know that that's necessarily recognized in terms of the level of support that we put behind making sure that we're able to continue what we've got going on in healthcare here in Hawaii.
Well, let me just finish by saying my organization has an annual meeting every year. We just had ours in Seattle. And at our roundtable discussion, we had a Medicaid director, insurance commissioner, exchange director, legislator, a public health commissioner, all talking, and they were incredibly aligned in their vision. And I was struck by how far we've come. And I will just say I have participated in forums like this around the country, and all kidding aside, I am really struck by the alignment of your vision. Not to suggest that it's easy to get there, but you do have to start with a vision and leadership to achieve it. And I'm really honored to spend the time with the leadership in this state that seems ready to take a very good system and turn it into an even more excellent one. So I thank you for your commitment to improving the health of Hawaii.
I would very much like to thank Alan and all of our participants in this panel for your candor and your wisdom and your collaboration. So thank you again. And we are at the end of the day. I want to take this opportunity to again thank all of our sponsors, our planning committee, staff and volunteers that made the day possible. I would especially like to thank all of you who are out here for participating. Many of you were participating in our breakout sessions as informants, others as part of the audience and questioners, and all of you have provided invaluable work in furthering our agenda for healthcare transformation. I think that we should really pat ourselves on the back because we are doing such a good job in such a wide-ranging area. And I'm just very proud to work with all of you. Thank you very much. I hope that you'll stick around for a little while longer. We are going to have no-host cocktails, and I, for one, am definitely ready for a drink. Thank you very much.